The following program does not necessarily represent the views of the Trinity Broadcasting Network.
Hello and welcome to this edition of Joy in Our Town. I'm Ann Farrell-Tata, your host, and I am more than delighted today to welcome my guest, Dr. Deepak Talreja. We are in for a treat today. Dr. Talreja is the president of Cardiovascular Associates and Bayview. He is also an associate professor of cardiology at EVMS, and he has a lot of other credentials as well, but we're going to get right to the program. Our issue is health, and our topic is cardiology. So welcome and thank you so much for being here today.
Thank you for inviting me.
So before we get started, can you tell us a little bit about what a cardiologist does and some of the different
Absolutely.
breakdowns?
So cardiology is really a focus on the treatment of heart and vascular problems. So to become a cardiologist, we go through medical school training and then train in general internal medicine, which is kind of diseases of the body as a whole, and then focus on the heart. And really, if you're simplifying it down, the heart is a mechanical organ. It's part plumbing and part electrical wiring. We have an electrical system in our heart, and often subspecialists called electrophysiologists focus purely on electrical issues. And then the plumbing part of it, I'm actually an interventional cardiologist. That's my subspecialty training. We deal with the plumbing, putting in stents, fixing blocked valves. We do a lot of imaging, and there are specialists who can do stress tests and ultrasounds of the heart. There's a lot of different ways we can look at the heart.
And so now they also talk about prevention. So not only do you treat patients, but do you also see patients to help prevent?
What a great question. So traditionally, the focus of cardiovascular disease and a lot of medicine has been treating a problem after it evolves. And you know, if you're thinking about fixing something in your house, it's always worse to wait until something's been destroyed or severely damaged and then try to go back and repair the damage. In this day and age, our focus really has shifted a lot, not only to treating problems that exist, but to preventing those problems from developing. So whether it's through nutrition, exercise, using medicines to prevent the buildup of cholesterol or heart artery blockages, that's become a huge focus for us.
And so you talk a little bit about what you specialize in. You're more of the plumbing side,
so
intervention.
I'm an interventional cardiologist.
And what does that do? What do you do?
Absolutely. One of my key jobs is I take care of all sorts of cardiovascular disease, but based on that subspecialty, when someone has chest pain, shortness of breath, angina, symptoms where the heart's not getting enough oxygen flow in it, I'm one of the people that comes in and finds the blockage, and if we can fix it by putting in what's called a stent, we do that. So an artery is like a tube or a pipe. Now, it's a living pipe. It's not a plumbing pipe where it's purely a matter of just cleaning it out or roto-rooting it. What we first want to do is give the artery health, and that comes through the right diet, through exercise, through stress reduction, and we can talk a lot about that. But when it gets to be very blocked and a patient's having active symptoms, what we'll do is through a little IV we put in an artery either in the hand or in the leg, we can pass wires into that blocked artery and pass a little balloon in there. And we use a balloon to expand and open up the artery, and then the balloon gets taken away. Or we use a stent. A stent is a metal coil that we place inside the artery. It pushes the plaque to the side. And for example, someone having a heart attack in the middle of the night, we can put one of these stents in and immediately restore blood flow to the heart. And a typical example I'll share with you, I had a patient recently who's a firefighter, and his story's been all over the news. He had chest pain after running a race, and he went to his wife and said, "My goodness, I don't feel right. I think I need to be seen right away." He is with the fire force in this area, but he lives in the Outer Banks. And so she said, "Do we need to call the ambulance?" And he said, "No, I think let's just drive in." Well, unfortunately, on the bridge on the way over, he had a cardiac arrest.
Oh, my goodness.
She started CPR in the car. The helicopter landed on the bridge, and it was in the middle of the night. They brought him to the hospital I was at. When he arrived, his heart was pumping about 5% of the blood, and he was on the ventilator, very sick and dying. I put stents in, opened up the artery, put in some special pumps that helped the heart. And it was actually interesting, as I went out to the waiting room, the whole fire force was there, and I thought, who's protecting the city? Because those poor guys, they're so loyal to each other.
Yeah.
And we said he had probably a 50-50 chance of making it through the next 24 hours. Now, that was a year ago. He recovered beautifully. He went back and rejoined the force and got back to normal. And that's what we can do in interventional cardiology, is
That
take
is
someone with a massive
amazing.
heart attack. It's very rewarding because you can very quickly see results.
And is there a typical age, or what is the age?
So the age spectrum's huge. We've taken care of and put stents in patients over 100 years old, and the youngest person I personally treated was 12 years old. Now, most often this is a disease that gets worse as people age. It's a little bit more common in men than in women. However, heart disease is the leading killer in both men and in women in this country. So we see men, women, typical ages are somewhere between 40 and 80, but we see extremes beyond and below that.
Now, you took care of this 12-year-old, but are you a pediatric cardiologist?
So I'm not trained as a pediatric cardiologist, but I and many of my colleagues work very closely with the pediatric cardiologists. So because of my subspecialty interests, I'm co-credentialed at CHKD, and the pediatric cardiologists don't deal with stenting much. They deal with
Yeah.
more fixing congenital problems. So when one of those situations comes up, I usually go over and help with that.
That's so unusual for a 12-year-old, though, right?
Very
Please tell me
unusual.
that.
Very
Was
unusual.
that a family history or genetic problem?
Yes.
Or?
So it was a combination of some congenital abnormalities and then a genetic issue where cholesterol levels are much higher than they should be.
So is genetics the predisposing? Is that one of the highest reasons? Or
Yes.
is it diet?
It's a combination, and for different individuals, for some people it's more driven by genetics, some people it's more driven by poor health, by diet. But really it's a combination. We say it's almost like a police officer with a gun. In order to have a gunfire, you need two things. You need a loaded gun, which is your genetics, and then you need someone to pull the trigger, and that's your environment. One of the things that's really been an area of tremendous interest this last 24 months for us is we've long known that there's a genetic deficiency where people can have really high cholesterol levels. A normal bad cholesterol or LDL cholesterol is something like 100 or 160. And some of these patients have LDL or bad cholesterols of 400 or 500, which is terrible. And they tend to die in their 30s and 40s. They don't tend to live to really mature adult years. And we have medicines that can help with that. Those are patients, though, that need to be identified early, and they need aggressive prevention early in their lives.
You know, that was another question that I had is if you do have a strong family history, is that something you should go in and just, I mean, what tests can they do to say if you're predisposed to having heart disease?
That's a great question. And we know some of the answers to that, and we keep getting smarter and getting more and more answers. But absolutely, believe it or not, the American College of Cardiology and the American Academy of Pediatrics have said together that if you have a very strong family history, for example, these families with familial hypercholesterolemia, which is a known genetic defect, screening should start at age 2. Between
Wow.
2 and 4, people need their first cholesterol measurement. Now, that's relatively rare,
Yeah.
but for the average American with a strong family history, or some family history of people who've died in their 50s, 60s, or had heart disease at that age range, which is very common, now it's recommended that the first cholesterol levels be drawn before age 18.
So is that the biggest indicator, the cholesterol level?
That's the biggest one we can identify right now. It's easy to measure cholesterol, can be done fasting, non-fasting, it's inexpensive, and that has a very high prediction rate. But we're constantly developing new markers. For instance, inflammation is known to be another issue as well. And there's a test, for example, called the C-reactive protein. When you or I get sick, our bodies make inflammatory factors, and C-reactive protein is one. And if you have heart disease that's festering on the inside but not bad enough anyone can catch it yet, your C-reactive protein levels tend to be higher. So there's more and more things we can measure. And then, of course, we have a lot of imaging tests we can do. We can do stress tests. We can look at plaque within the arteries in the body with ultrasounds, with nuclear imaging, with CAT scans, with MRIs, and with catheterizations where we use dye and x-rays to look for that.
So do you work with the radiologist for that? Are there cardiac radiologists that specialize? Or?
Yes, so it's interesting. In the world of medicine, just historically, there are things that simply are the way they are.
Yeah.
You know, Hong Kong and China are different countries. Why? They're so close to each other. It's just the way it evolved. In medicine, cardiology very early on evolved to do all of its own radiographic imaging. So although we actually partner with the radiologists, most of the cardiac imaging in this area is done by the cardiologists themselves. Although, again, we have good relationships and work closely together.
So you have to be board certified in radiology as well?
Not in pure radiology, because truthfully, the radiologists stick to mostly the things outside the heart in this region,
Oh,
although
yeah.
some co-read heart stuff. But part of the cardiology certification requires that you understand that imaging.
That is amazing. Can you talk a little bit about the TAVRs procedure?
Yes. So I told you a lot of cardiology, what I do is related to plumbing. And so plumbing has two different aspects. There's the blood flow that goes to the heart itself, and that's what causes heart attacks when those arteries get blocked, and that's the world of stents. But also the heart pumps blood to the whole rest of the body. And the heart has 4 valves, and 2 valves in particular on the left side of the heart, the aortic valve and the mitral valve, can develop problems where they leak or they become narrowed and can't open. And if you have a valve that should be opening to allow blood flow through and yet it doesn't open well, like the aortic valve with a condition called aortic stenosis, then that patient can get so sick that they can't move around, they get very short of breath with even the minimal amounts of activities that are part of daily living. So aortic stenosis traditionally has been treated by an open heart surgery where we open the chest, cut out the old valve and replace it. And that still is the standard of care. That's still the way we treat most patients. But you can imagine many sicker, older patients can't survive a procedure. Their risk is so high that the treatment's almost worse than the disease.
Right.
So over the last decade, we've developed techniques to go in through an artery and implant a valve on a balloon into the old valve. And so now, and it really is amazing because one minute you have a valve that's not working, the patient's very sick, you deploy the valve with the balloon, and minutes later, the whole pressure difference that created is gone. And so even sicker and older patients, this procedure is called a TAVR, or transcatheter aortic valve replacement procedure.
So, and are you one of the leading areas that do that?
So this
they're not doing it everywhere, right?
No, they aren't. In fact, there's been very limited release. You have to have access to special operating rooms and specially trained teams that combine surgeons and cardiologists. And in this area, we have a team of 2 surgeons and 2 cardiologists that work together, and we can do that. And in fact, our waiting list is pretty long because around the state, many patients are referred to us from other areas.
And what is the typical age for that kind of patient?
So that's reserved for patients that are a little bit older. I see many 50-year-olds who come and say, boy, I sure would like to have this done minimally invasively, but that's not FDA approved in this country as yet for the low risk or even the intermediate risk patients. The average age is probably in the 80s for patients we do this. We've done it on patients as old as 100. And again, you have to individualize to the right patient. It has to be a 100-year-old who is functional and has something really to recover too.
So if they're 50-year-olds, you would still do the...
We still do.
Really?
Now there are minimally invasive approaches, but you can't use these valves.
Why is that?
Great question. The reason is, whenever in medicine we always like proof that something is the best available therapy. And since these valves in the US have only been really available for the last 5 or 6 years, the FDA has said, let's see 10, 20 years of success before we extend it out to other groups. And frankly, our surgeons do such a nice job that a healthy 50-year-old can get through the surgery and be out of the hospital in a few days. So since we know those valves can last for a very, very, very long time, and we have historical proof of that, that's still the favored approach. But the world's evolving very quickly.
And are you doing a lot of studies right here in Hampton Roads?
Yes, we do a ton of studies across the spectrum in cardiovascular disease. In fact, we were involved in the pivotal studies that got the FDA to approve the TAVR procedure. We're also involved in studies on exercise, diet, nutrition, different stents. For example, in the world of stenting, a stent is a metal coil, and once you put it in, it's there forever. Many patients say, would you ever take this out? And the answer is you can't. Once a metal stent is put in the body, it stays there forever. The body grows around it. The next generation of stents being developed are what are called bioabsorbable. We put the stent in, and slowly it dissolves away. So a year or 2 later, the stent's gone and the artery is healed and has repaired itself.
Wow.
And we're involved in some of those trials as well.
So do you initiate these, or do people come to you and say, we have an idea, or do you say, I have an idea?
Both are true. For example, in the world of TAVR or those stents, those are trials that were nationally created, and then we locally have a principal investigator who brings that study to the area under the auspices of a much larger national movement. On top of that, we do have some studies that we generate here. An example of that, one that I was what's called the principal investigator for, is we had an interest in discovering more about nutrition and diet. So we started a study in the Hampton Roads area. In fact, most cardiology studies have to have a cool name so people will remember it and say, okay, this was the Orion study or the Jupiter trial. So we called our study the Virginia Beach Diet Study. And it stands for an investigation. The V came from investigation of, and when you put in Mediterranean and Paleo and all the diets in it, that's how we came up with the title. And that's been presented around the country at national meetings now. We had...
I'm gonna cut in for just a second because we've got to take a break, but I really want to hear about this. And that's a perfect segue to our next session where we're going to be talking about healthy eating and some of the preventative things. I'm Ann Farrell Tata, Joy in Our Town. Stay with us. We'll be right back with Dr. Talreja. Welcome back to Joy in Our Town. I'm Ann Farrell Tata, and I've been joined by Dr. Deepak Talreja, who's the president of Cardiovascular Associates in Bayview and also an associate professor of cardiology at EVMS. And we're switching gears right now, and we're going to be talking about heart health. And you were just starting to tell us about a study that they've been doing and called the Virginia Beach Diet Study. And
Yes.
Please continue, and welcome back.
Thank you so much. So the Virginia Beach Diet Study was a study we generated locally. We've long known that there are a lot of things that influence heart health: stress levels, food, nutrition, smoking. Smoking everyone knows now, and hopefully we're most of the way there to getting most people to be convinced to quit. Stress is one. I'll just deviate and talk about that for 1 second. It's interesting. They've done some fascinating studies where they've looked at arterial reactivity and stress levels. They, for example, brought in 30 healthy young people, and they looked at their arteries before and after an intervention. The intervention was they made them watch a movie, and they had them watch a comedy movie and then the movie Saving Private Ryan. And what they found, and the results are amazing. After 2 hours of entertainment, but stressful entertainment, the arteries actually work less well. So there are a lot of things like stress that just have dramatic effects on the heart. And we all know that the cost of medical care in this country is huge. It's outstripping GDP and other measures of what our production is. We know that we can't keep affording to provide care like we are, so we've got to make our population healthier.
Right.
So with the diet study, we got 4 groups of 100 patients, and we came up with the idea of testing this. We thought it'd be great for the community. We got volunteer clinicians, nurses, doctors, and people to participate. And we approached a couple of the local industry companies. In fact, one that does some of the more advanced cholesterol testing. And we approached them and said, will you do the cholesterol test for us for free if we put in all the effort to do this? And they agreed, and they actually even helped offset some of the costs. And then eventually the Cleveland Clinic and the University of Alabama heard about what we were doing and approached us to ask if they could have some of the blood we were drawing to do other newer tests on as well.
Wow.
So we brought in these 4 groups, and they were a vegan group, a Paleolithic diet, which is kind of like an Atkins low-carb, high-protein diet, the Mediterranean diet, which has been very favored in many cardiac circles.
What is that? The
Mediterranean diet is based on a Greek-Italian lifestyle. It's more fruits and vegetables, whole grains, exercise, daily consumption of fish, less red meat consumption, exercise. Many studies have shown that's very heart protective, including large studies across different places in the world. So it's maybe a little bit between those other two. There's still meat in it, so you still have protein, but it's a little bit more vegetables and fruits than the traditional American diet, which I'm laughing because it's called the SAD diet, the standard American diet, and it truly
That
is
is
sad,
sad, yeah.
and it has sad effects on our population. And then the 4th diet was what the American Heart Association and American College of Cardiology recommend, the DASH diet. So 400 patients total, 100 in each group. We had them come in every single week. They logged everything they ate, and we gave them points for good things and took off points for bad things. They met, they counseled. We had physicians, nutritionists meet with them. So for 60 days we did that. We checked blood work at day 0, at day 60, and again at 6 months later. And the results were really, truly dramatic. People lost up to 60 pounds in 60 days. And what was amazing was we didn't ask them to limit their consumption at all. We didn't ask them to exercise at all. All we asked them was eat healthier stuff, eat in line with this, eat more natural foods. Instead of going and getting processed foods, get real foods. And the results were very dramatic. There were significant reductions in the bad cholesterol, significant elevations in the good cholesterol. Everyone's question was, and the groups got a little bit competitive with
I'm
each
sure.
other, as
Did
you
they
can
know?
imagine.
They knew that they were doing this?
They knew they were doing it. They knew all the groups were doing it.
Oh, yeah.
They chose their own group they wanted to go
Oh,
into. We
wow.
allowed them to do that.
Yeah.
And then we did reviews of all the data periodically along the way, and all the groups got to see how each group was doing.
Did
And
they meet together?
They met, not during the study,
Oh, yeah.
but at the beginning and at the end and at 6 months, they all came in for blood draws together, and we all had joint sessions where we went over data. But individually, they met to go over their weekly logs.
Yeah.
And it was funny because they truly got a little competitive with each other, which was great.
Of course.
And by the end, what we saw is every group did better than the traditional standard American diet. So just getting on a diet and sticking to it makes a huge difference. There were some differences. The Mediterranean diet had the best rise in good cholesterol. The vegan diet had the best lowering of bad cholesterol. The paleo diet had the best improvement in triglycerides. All of them had favorable profiles overall. Another thing we saw was blood pressure. Normally, as a cardiologist, if someone has high blood pressure, I'll put them on blood pressure medicine. And if the blood pressure medicine lowers their blood pressure by about 10 millimeters of mercury, I think, great job, I improve things. The average drop in blood pressure was about 12 millimeters of mercury with this study. So that's preventing people from going on medicines for blood pressure in a very healthy and natural way. So it's very exciting to see results like that. And one thing that was neat is, I wish I almost could have brought you into the room as we did our final sessions with each group, because people were saying, there were some restrictions as to who could and couldn't be a part of it. If you were diabetic, we didn't let people in because that tends to skew the results a little bit.
Yeah.
But many participants had families where the whole family went on the diet, including maybe a diabetic or heart disease stricken family member. And what they were saying, I mean, people had tears in their eyes and were saying, this has changed my life. Doing this for 60 days, I'll never go back. I feel better. I've lost this weight. I'll never go back to what I was doing. And it's just so rewarding to see results like that.
So what was the gender and age, and how did you pick the people?
Great question.
Or
So
were they patients? Were they already patients?
They actually, we allowed people to volunteer. We published it in the newspaper, and then we put flyers out all around the town. And people would come and volunteer. You had to be 18 years old at least, and we said less than 80 years old, just to keep it to be a fairly represented population. At the end of the day, as people volunteered, we found that about 70% of the participants were female, 30% were male, and I think the answer for that is more women are a little bit concerned about their weight, quite honestly, than men, just in our population, so that probably drove that. The average age was in the mid-50s. We excluded people who had diabetes or active heart disease. So it was meant to be a fairly healthy population. And the results, again, were truly tremendous. We presented them at meetings of the National Lipid Association, the American College of Cardiology, and a bunch of other large groups around. So it's been exciting.
So that only kind of adds to the confusion, though. What is the right one?
What a great question. We see that again and again. Everyone's question is, what's the right diet? And I'll tell you, as a practicing cardiologist who has an interest in this, and that's one of my real foci in life, my answer is, I always ask the patient, what do you think you can do? Because more important is they'll stick with it. And so if I try to make everyone a vegan, which I'm not myself, but I do think that's a great diet, I won't succeed. A lot of Americans simply can't do that. In fact, I think the majority have a hard time doing that. But if the average patient can eat more fresh fruits and vegetables, 5 servings a day at least, eliminate soda from their diet, have healthier cuts of meat when they eat meat, and try to eat more fish and chicken and less red meat, avoid fried foods, that's what 80% of the diets kind of agree with at the end of the day, and that really makes the most difference.
Are people overall, do you think they are changing their diets and as they become more aware?
I do believe that's true, and I think the two things that I see fueling that trend are, I think the younger than me, the next generations down, are becoming more and more health conscious, more interested in activity, more aware of their health and other concerns. And then I think the other thing is, as heart disease, as we learn more about heart disease, as it's pushed to the population, as there's more media spots on heart disease, people become aware of this. And so I do see our population becoming healthier. Unfortunately, if you look at national statistics from the NIH, the National Institute of Health, what you see is our population as a whole, including all generations, is becoming more obese, higher rate of diabetes, higher rate of high blood pressure, and that's fueling increased costs in medicine. So although I see nice trends in the younger groups, we got to spread it to everyone.
Well, why is that? I mean, I do know a lot of the healthy foods that they push are high caloric.
Yes, and that's it. I think you nailed it. It's interesting. We're constantly faced with a battle every day. You think about 100 years ago when most people lived on farms, and to get the food you ate, it only went through a few hands before it came to you. Nowadays, you go to the supermarket, and most of that food has been processed extensively. There's a lot available, and it's high caloric. You say it perfectly. I'm a cardiologist. If you go to my office and you don't have food and you want a snack, there's no apples or bananas sitting around. We have a snack machine. And if you go get a pack of M&Ms, which I can finish a pack of M&Ms in maybe a minute or two, that single pack of M&Ms has as many calories as 5 apples. Now, I'm not going to eat 5 apples in a whole day, but I can polish off those M&Ms quickly. And so our stomachs have volume sensors and not calorie sensors. So when you have calorie-laden drinks, when you have energy bars and things made for people who are burning a lot of calories, and yet we're all so busy, we're working and not exercising, we get excess calories on and no calories off.
Well, and even healthy things like nuts, you know, everyone's like, eat nuts. Well, nuts are really caloric.
Exactly. So if you're exercising, that's a great snack. But if you're sitting around all day and doing nothing, those calories will eventually add up. And although they're healthy in general, they're still calories, you're right.
So what about exercise? I mean, if a family has a family history and they're predisposed to heart disease, what if they only exercise? Would that make a difference?
Absolutely makes a difference. In fact, there was a beautiful article published in the Journal of the American College of Cardiology about 6 months ago looking at intensity of exercise and survival. And they grouped the people into 5 groups. And if you look at the group who did almost no exercises versus the next 4 groups, what you find is mortality is death is 20% higher in the group that does very little or is sedentary. And even doing as little as about 20 minutes of exercise 3 to 4 times a week reduces your mortality by 20%. And interestingly, after that, the curve doesn't get much steeper. So a marathon runner, frankly, versus someone who's exercising 4 or 5 days a week doing 30 minutes of exercise, as far as cardiac mortality, your risk of dying, you're getting a lot of your benefit from very low levels. If most Americans, and that's what the ACC says, the American College of Cardiology says, 30 minutes 5 days a week is what's recommended of simple exercise, walking.
Yeah, they can walk.
Exactly.
Or park your car far away and
park your car further
yeah.
away. Absolutely, that's a perfect suggestion. And in fact, what we say is if you can't dedicate 30 minutes to exercise, count your steps, 10,000 steps a day with a
Yeah.
Fitbit or a step counter. That counts as a day of exercise.
So what's on the horizon as far as medicines and
Great
you know,
question. Cardiology is an exciting area because there's tons of new developments all the time. We talked about valve disease and these new TAVR procedures.
Yeah.
That continues to evolve. The thing that's hit the news waves this last month, and in fact, again, locally, I was the principal investigator in the study for this. So I told you about familial hypercholesterolemia, where people have horribly high levels of cholesterol and they die very early. For a decade, we've known about an opposite condition, which is abnormal, and medicine always has these complicated names, but there's an enzyme we make called PCSK9. So people have deficient PCSK9, and normal LDL or bad cholesterol is like 100 or 160, somewhere in that range. These people have LDL cholesterols of 10, 20, 30. No heart disease, they do great. So we've worked for a decade to figure out, can you make a drug that does that? And now what we've done is harnessed our own immune systems. 5 separate companies are quickly moving to market, and they've produced monoclonal antibody injections. Every couple weeks you inject yourself with an antibody, and your own immune system gets rid of some of that enzyme, and people's cholesterol levels plummet. I've had a lot of, because I direct this trial, I've had patients in it, and the FDA agreed with what we call compassionate use, which means for some of those patients, we're now having them on the drug even though it's not been approved. And this last week, some of our patients went up to DC along with people from around the country, and the FDA advisory panel has tentatively made a suggestion to the FDA to approve these PCSK9 inhibitors by the end of this summer, and that will be, the National Lipid Association believes this is the decade of PCSK9 inhibition, and that will further drive down heart disease rates.
will this take place of the current drugs that are out
Great
there?
question. So we have good drugs already.
Yeah.
Cholesterol medicines called statins, like the statins,
Right.
atorvastatin, simvastatin, and many others like that. There's niacin. There's many other drugs like that. Many of those have problems with patient compliance because people fear they have side effects with it. And many patients are on them but can't get to the right levels. So it's believed this will be an add-on, and eventually it'll take a lot more data before people are comfortable replacing anything, but maybe that'll even happen. But right now it's more of an add-on or for use when patients can't take those. And again, it's not approved yet, but that's what's coming.
Yeah, well, that is all exciting. And I cannot thank you enough. This is absolutely fascinating. And I know people are going to want to reach out to you when they see this. And I think we're going to put your phone number up on the screen. But Dr. Talreja, thank you so much. This is Joy in Our Town. I'm Ann Farrell Tata, and I've had the most delightful time with Dr. Deepak Talreja. Thank you so much, and we'll see you next time.
Thank you. That was fun.
Okay, you are amazing.
Thank you.
This program has been sponsored by the Trinity Broadcasting Network and made possible by your telethon dollars. Your continual support can keep Joy in Our Town brought to your home every day. So write Joy in Our Town, P.O. Box A, Santa Ana, California, 92711.